Welcome to TCN Talks. The goal of our podcast is to provide concise and relevant information for busy hospice and palliative care leaders and staff. We understand your busy schedules and believe that brevity signals respect. And now, here's our host, Chris Como.
Hello and welcome to TCN Talks. I'm excited. Our guest today is Bree Owens. She is a licensed clinical social worker and a co-founder of the Holding Group. Welcome, Bree.
Thank you. Thank you so much for having me on, Chris. I'm really excited to talk with you today.
I'm super excited too. I was reflecting as we're doing show prep, and it just felt so by chance when I first met you at Home Care 100, and we almost felt like we were just walking, and Katie Lands was the common point, and I've just so appreciated getting to know you, and especially the work, and which is probably a good segue. What does our audience need to know about you?
Well, in addition to being the co-founder of the Holding Group and a licensed clinical social worker, I'm a mom to a 9 and a 7-year-old, which is definitely the hardest but most rewarding job I've had. I have a very supportive partner. He's wonderful. And as I was reflecting for this podcast, I was thinking about what I want people to know. And one of the things is that my roots and entrepreneurship is kind of in my blood. My parents opened an auto repair and body shop when I was 2. And my dad would be working on a car in our driveway and put me in the car seat and throw me snacks to keep me happy. And then they built that business to now it's been here 42 years in Denver. Wow. And employs 25 people. And actually my husband is one of the owners now. So I was taught from a very early age that you can build meaningful things and you don't have to wait for permission.
That's pretty awesome. Well, how did you come to found the Holding Group? Where's that in the story?
Yeah. Well, it's a long story, but a good one. So I began my career at a level 1 trauma center here in Colorado. And just seeing how much traumatic-based end of life came in to that ER and the heartache around that was so eye-opening to me. Lots of accidents and gunshot wounds and things of that nature. Wow. And my job was to find the families, bring the families there, bring in the physician to tell them what had happened, and then to support them in their grief. And through that process, I learned, one, that role had a shelf life for me. I was there 2 years. But 2, what those people would have given to know 5 minutes or an hour before what was going to happen and what they would have done with that time, what they would have told the person that they love. And then I saw all of these folks coming in with serious illness. And it felt to me like as a system, we were robbing them of that time by not having conversation about the progressive nature of their illness, what to anticipate, helping them to figure out what the paths available to them were. So that's really where I fell in love with palliative care and found that. And so I then went to work at a hospice who had a palliative care branch. And met some incredible like-minded social workers and realized at that time that there was a lot of power in the social work role. And so we really began building this model 15 years ago and have researched and iteratively improved it ever since. And we developed this model, and it reflecting on our history, it really sits at the intersection of value-based care versus fee-for-service. So I would not have had those words at the time, but we were passionate social workers trying to make a meaningful impact for those that we were seeing with serious illness who were not yet connected to hospice. And the work did and does require a profound amount of indirect time where you're not face to face with a patient. And the way our contract had been set up between our employer and the payer, we could only bill the payer and be reimbursed for face-to-face visits. right? Sounds like our fee-for-service system. So we would be told to see a vented, unresponsive patient in the long-term acute care setting for the sixth time, so that we could place the claim. When the real work that needed to be done, for example, was with the medical power of attorney out of state, helping them by phone in their process, having hard conversations about what their person would want, and coordinating with the medical team when we discovered that there were gaps in understanding, in their medical understanding, that they needed to hear from a medical provider. So we would assess what that was, really titrate that information down, or distill down that information rather, to the provider. They would be able to come and fill that piece in, and then we could help them move forward in their process. So, we didn't set out to build value-based care, but that's kind of a natural consequence when you're solely focused on the patient and whoever they define as their family. So, you had asked about our name before, and we built this intervention at its core to hold these patients and families, thus our name, the Holding Group, to create that space, that container, that sense that they could bring their full selves. What we didn't realize, being our idealistic and very focused social workers, was that the larger community would see that that word or that term of the Holding Group as a financial institution. So we still struggle with that today, but that's the purpose of the term.
I think that's beautiful. And actually, the more I've gotten to just appreciate you, Bree, I think you've got some incredible superpowers. We actually use that in our Anatomy of Leadership podcast. We'll ask people, what do you think your superpower is? Mm-hmm. But listening to your story, being a social worker, but having entrepreneurial skills, that's a bit of a unicorn kind of skill set of the two together. But as you were describing your pathway, I kept asking myself, is that where the name came from? Because holding space for people, which is so antithetical, because if you follow the dollars, I had a really interesting first mentor in hospice. He was a really hard person to work for because he was just so crass. His background was in kind of naval, like the VA, Naval Hospital. But he had these really terse learning lessons. And he'd say, Como, if you want to figure out why people do what they do in healthcare, follow the dollars. And it's a very perverse way to explain why is this crazy thing happening?
Yes.
But yet you're just such someone in the learning mode. And I totally get it now. Holding space is really what you guys do. Well, maybe that's a good segue. So what's the unique value proposition going forward in the healthcare continuum that you're creating, and maybe some successes you guys have had?
Yeah, absolutely. Well, we founded the Holding Group in 2012. So we've now had a 12-year history and have learned a lot along the way. We've also had the good fortune to team up with a principal investigator, palliative physician at university, Dr. Sarguni Singh. And she has really helped to propel the research of this model forward. And it's, when you do academic research, you have to come up with some sort of fancy acronym. So ours is ALIGN, which is assessing and listening to individual goals and needs. And so really this intervention looks really different in its deployment, depending on what the unique needs of a patient and family are. And as we said, we're creating space for people to bring their full selves. And our goal is to help them achieve informed consent. So informed consent of the various implications of the paths available to them. Of course, they have to understand their medical picture. But also, it is a financial, practical, psychosocial, spiritual journey. And I think sometimes social workers and medical models can become resource hander-outers, or that's kind of what they're seen as their value is to hand out resources. When instead, if we bring them to the front of this intervention, they have the ability to provide psychotherapy, helping people in their process as it relates to their disease progression. And that humanistic view is what the change maker is. And so from very early on, our outcomes were pretty astounding in the sense of saving money. And that is not because that's what we set out to do. That is a result of helping people understand the paths before them and the choices available in the context of their specific serious illness and their status in their disease progression. And, people don't want to die in acute settings. They don't want to die on a ventilator. They don't want their world to be interrupted by the cyclical revolving door of hospital, subacute, home, hospital, subacute, maybe never home into long-term care. If we can have these conversations more upstream, we prevent that acute expenditure. And so, our very first pilot was in the LTACs, in the long-term acute care, and that showed a 30% decrease in rehospitalization.
Wow.
And a 30% increase in the patient and family satisfaction. And so as we've looked at this over and over, goal concurrent care, overall cost of care is tremendously decreased by having these conversations upstream into, there's a social work saying, start where the patient is or start where the client is. And so that's what we do. We meet with them and we listen to who they are and who is around them. And we build our plans of care based on that unique individual. And so if you do that, right, and you're helping them to achieve informed consent and then supporting them in whatever path that they choose. It's not our job to decide what path they choose, but it is our job to make sure that they're informed and therefore can know which path is most aligned with their values.
Wow. Bree, how many employees do you have now?
We are a team of 14.
Wow.
We were 4 social workers who started this in a garage in 2012. Yeah, we've been building, and the opportunities it's just the right time in history for this work.
So it does feel like, and this is helping me because I feel like I'm even learning your model better as we're doing this podcast. It does feel like that care plan is part of the just unique value proposition and how you discover it. So in that care plan, you probably discover the need for other coordination of other aspects and maybe even a little bit more the medicalized aspect. So is that true? And then as that evolved, as your other collaborative partners that you've had to seek out?
Mm-hmm. Yeah, absolutely. So I think you nailed it. I mean, certainly if there's a symptom crisis of some kind going on with a patient, then the first step needs to be that medical intervention, because we can't engage in these conversations if someone is in pain or discomfort. And so those cases make the most sense to have the medical provider be the first point of intervention. But there is many, many more for which sending a skilled and trained palliative care social worker to that patient and family to do a comprehensive assessment. And so our model covers 5 major domains. So their understanding of their illness and treatment options, including their eligibility for hospice and other palliative care programs, their goals of care and completion of advanced directives, their living situation and custodial needs. I mean, this is a huge one that brings in Medicaid eligibility, caregiver needs, caregiver fatigue, certainly the caregiver or patient-defined family concerns, and then the emotional and spiritual support needs. So we are looking at those domains. One of the problems with palliative social work is there hasn't been a whole lot of structure built around that role. And so that's what we've really sought to do and have done. And that assessment then serves as, who do we need to bring to the table to help this person and their needs and in meeting informed consent? So did we assess in that initial visit that they're receiving chemotherapy for a cancer that they believe to be possible to be cured, when it's very clear that that treatment is to prolong their life, but that cancer can't be cured? But the patient and the family have either not been told or have not observed that, have not really digested that. And so our goal then is to bring the oncologist to the table. They have that relationship with the oncologist, and we can tell the oncologist, hey, we met with them, this is the specific piece that they're missing. So it's about using the medical provider's time effectively and efficiently to be able to come in and fill that gap in knowledge, and then we can process further. So we could not do this work without being able to leverage our medical colleagues. But it's a matter of trying to be efficient, effective, and just patient and family focused, where social workers are very good at assessment, very good at understanding systems and family dynamics. And so we are the right person to build these plans of care and bring in the needed providers to address the needs that we've found.
Thank you to our TCN Talk sponsor, Dragonfly Health. Dragonfly Health is also the title sponsor for Leadership Immersion courses. Dragonfly Health is a leading care-at-home data, technology, and service platform. With a 20-year history, Dragonfly Health uses advanced technology and robust analytics to manage durable medical equipment and pharmaceutical services as part of a single efficient solution for caregivers, patients, and their families. The company serves millions of patients annually across all 50 states. Thank you, Dragonfly Health, for all the great work that you do.
Well, one of the, I hate it, sometimes wonderful phrases become cliche potentially, but just listening to something, I think Dr. Morris taught it to me, Dr. John Morris, who both know is right care, right place, right time.
Yes.
That feels like keeps coming to me listening to you. Does that feel pretty accurate? Like there's this overarching theme of what you're after here, what your team is able to do is really get that right care, right place, right time, and add incredible value, which you'd almost sit there and people go, wow, there's a real need for that? Yeah, because of the way the system works today and all the perverse incentives. Does that provoke any comments?
Yeah, I think it provokes a lot of comments. I mean, right care, right place, right time. I think that's what I am motivated to build towards. I don't think we're there. I mean, I think we get parachuted into these cases, oftentimes very late in illness progression. And sometimes we're having a single encounter. Our average initial visits are 90 minutes to 2 hours. We're having that initial assessment encounter, and we realize right away this patient is hospice eligible and they really are aligned. They just didn't really realize X, Y, or Z about that. And so one of the things that our intervention does is increase hospice length of stay. But if we could move upstream, we would just be much more able to provide right care, right place, right time. And our data analytics are getting so much better that we really can identify the right people better. I think that was less sophisticated even a couple of years ago. So I hope to get there. But that's why our intervention looks so different. The deployment, depending on the unique needs of the patient and family, is because we never know exactly what we're dropping into and where they're at in their illness progression.
Wow. I love your answer. I mean, there's so much wisdom packed into that answer of, compared to where we are today to maybe more idealistically where we'd like the whole system to get to. I love the way you answered that. And as something occurred to me, Bree, just as setting the table, because so many of our listeners are hospice leaders, a lot of palliative care leaders. And the reason why I thought you would be such a great guest, I think we may call this like innovations in the serious illness space. Because you are in this innovative space. It feels like the serious illness space is kind of the wild, wild west right now. And I mean that in a good way, that there are incredible entrepreneurs like yourself and your team that are creating great value, doing great work. And maybe some of our hospice peers might be like, well, that's what we're supposed to do. But and the fact that you worked early on a palliative care team that was part of a hospice organization, this is why many of our TCM members have created palliative care programs themselves, because hospice unto its own, yes, in an ideal world, we get that referral at a perfect place and a perfect time, and the system would deliver them appropriately and eligibly. But we all know day to day that doesn't occur that way. And so I don't know if that just provoked, but that's why I thought you'd be such a great guest.
Yeah, you asked me kind of who is our competition in this space, or who is doing similar or dissimilar work. And I have so much that I want to say, so I hope our listeners have a ton of time. But Dame Cicely Saunders was the start of hospice. She was a British social worker and nurse, and kind of came up with the originating philosophy behind hospice. And when we started to build palliative care, we built that off the hospice model originally. However, we built it without a payment mechanism. And so it did not have a structured reimbursable vehicle through which to provide the work. And so when I was really looking into innovations happening, a lot of them happen in the inpatient centers because there's a lot more flexibility around how you deploy resources in short-term acute care hospitals. So there's tons of efficacy around the ability of palliative social work to make outcome differences. However, we've really expanded into the home setting, into wherever someone calls home, assisted living, independent living, memory care, residential homes. And it has been really hard to figure out how to provide this work. And so, yes, hospice is 100% are in the place of wanting to provide more upstream support and innovation, but the payment mechanisms for that are not easily accessible. And so what is accessible, most palliative care that happens outpatient is from APP, who is providing E&M codes, at some periodic frequency to try to meet this need. And so we've been really constrained by what's available in the fee-for-service system. And social workers, I want to give a shout out to CTAC, the Center to Transform Advanced Care, because they put a bill in front of Congress to allow social workers to bill for advanced care planning. So there is a movement happening to bring social workers more into this work in a financial, as you say, no margin, no mission. We have to be able to figure out how to make this work financially. And I would say that we're still, as a society, figuring out the best way to define palliative care and to deliver palliative care. And that's where this push to value-based care, to training providers, social work providers within ACOs, within providers that are taking risk groups. There's an opportunity for us finally to scale, but our partnerships thus far, we were a little bit before our time, I think. And so we've had kind of this hockey stick style growth because it took the early adapter of Kaiser, our big partner in this area, to now get to the point as a society that people are moving towards value-based and taking risks and being financially incentivized to take risks. So I would say that, hospice is in a great place, but it's not easy because of the lack of available payment methodology in the outpatient centers.
Well, probably a good segue, Bree, because you are such an innovator. You probably also have a good bead of what are other innovations that you're seeing out there in kind of this space. Some of them might be similar, maybe dissimilar, because I use the analogy, maybe it's not a perfect word, but like the Wild Wild West. Yeah. I've used the analogy. I asked someone the other day, I'm like, do you know where the 49ers football team gets their name from? And most people go, no. Like it was the gold rush of 1849. And that's where people are like, oh, I didn't know that. And my analogy is that's kind of the serious illness space. Although you probably go, well, where's the gold? But people are seeing the potential for gold because of just the aging of America, the silver tsunami. Yeah. How many people are dealing with chronic illness and what that's doing to the overall already somewhat stretched healthcare system. Yeah. So my guess is you probably have a fairly good bead of just other innovations that are out there. So could you speak to that a little bit?
I have yet to find an outpatient in the home social work driven serious illness intervention. And, I just think that's because it's very hard to deploy financially, that you have to make these relationships directly with MA plans or ACOs. But there is just a ton of innovation in this space happening. And I just read on Hospice News, Jim Parker wrote an interview with Tom Lally, who is a physician here who has headed up Bloom's ACO REACH. And Tom Lally was doing fee-for-service primary care in the home for, decades. I don't know the exact year he started, but I know it goes back as far as our history, and was getting just whatever reimbursement was available, right? Not able to scale in that way, but was meeting this need. And then ACO REACH came along, the high needs ACO, and they have proven themselves the strongest saver in the country under that program with the reports that have just come out. And Jim Parker in this interview was asking about how they've done that. And one of the main ways is they're following these patients longitudinally, like we do. But they're getting involved upstream, creating rapport, and then they're having these conversations over time as the illness progresses. And that is what is just preventing this downstream expenditure that people don't want. And I think the baby boomers are really taking a little bit more control and wanting to engage in these conversations as well. And so there's just so much change that is happening and so much potential to do good in this field. And I want what we provide. I want it for myself. I want it for the people that I love. And I think if we just all keep our eyes on where a patient and family are struggling and try to find creative solutions to meet their needs, it's going to be a lot better.
There's a pretty cool innovation that's happening that's put out by CMMI, the guide model. And I think you're pretty excited about that. Can you just talk about that a little bit?
Yeah, I'd love to. So the Center for Medicare and Medicaid Innovations, which is the same one that kind of the testing side of CMS. I didn't know all this, so your listeners may be more sophisticated than I was, but they are the folks who put out ACO REACH and do all of these kind of test payment models to study them before they decide what's rolled out to the larger Medicare and Medicare Advantage population. So they released a program called GUIDE. Again, you have to have those acronyms, right? So it doesn't completely line up, but it stands for Guiding an Improved Dementia Experience. And it's an 8-year model, and it is to provide wraparound, comprehensive dementia support care to patients and their caregiver who have any stage of dementia, any type of dementia. And we were one of 390 participants that were awarded participation to deliver the guide model. And 90 of us started this year in July. And the reason we decided to apply for this program, it was very close to what we were already providing, except for a couple of things, which is it is much more upstream. So you have folks who are fast scale 4 and 5, and they are able to engage in their own advanced care planning, which is really unique in the dementia space, because oftentimes when you're having those conversations and completing those advanced directives, it's with the medical power of attorney. So being able to, as you know, we're talking about just bringing things more and more upstream, giving people more autonomy and control, that is a really exciting aspect of this program. And then you follow them for the duration of their illness progression until they admit to hospice, which again, hopefully we're doing that at the right time, because what a gift hospice is, right? I think that's the other thing that I want to really tell and show your listeners is it's about getting folks to hospice sooner who are eligible and aligned. And we've proven the ability to do that. We don't own a hospice. We wanted to remain independent, but we know that that they will be well served under that, and they will have time if we can get them there to do all the things that we all want to do at the end of our lives, to leave in peace, right? And so I think there's just so much to think about.
You were I think you were going there that there are a couple things within the guide that your organization doesn't do. Do you want to?
Yes, thank you, Chris. Thanks for getting me on track.
It's all good.
You can see
that's my part of this job here.
You can see my passion. Okay, yes, thank you. So the other incredible thing that Medicare has done, I think for the first time under this program, is they are paying for non-medical and home caregiving. So they are paying for respite care for the caregivers for the first time ever. Those who are in the moderate or high complexity tiers of dementia. So not in the early stages, but in the moderate and high. And if they have a caregiver, they are entitled to $2,500 annually of respite services. So that can be, they have to be offered in home respite, but you can also offer them day centers and facilities. And that is revolutionary. And I saw Katie Land speak at Home Care 100 a couple of times ago, and she had just talked about the pivotal role that caregivers are going to need to play, that in-home non-medical caregiving. And we have not invested in that. It's never been provided through Medicare. And so I think there's some movement happening there. We're realizing kind of the linchpins of society. I remember in COVID, realizing how much, teachers were the linchpin of society to keep everything else running. If we don't have kids in school, then what is that ripple effect? Kind of same thing with if we don't have caregivers and a way to pay for those caregivers. It really is a huge detriment. So that is the exciting part. We're partnered with Home Instead here in our region, who has been a phenomenal partner. There's things I could also say about wanting the rate to be more at market rate than CMS is providing. I will take this opportunity to say that, but it's a step in the right direction.
Good deal. And so do you see a role for, like, let's say you're doing guide in a market, is there, you kind of allude to it. So there's still that role for a hospice. So, can you just unpack that just a little bit more? Like, I imagine you want good hospice partners because you providing that guide, there's the need for, sounds like a good private duty partner, some good respite options, but then also that good hospice program at the end, and that stitches together the continuum.
Absolutely. And that's always been our goal, is to decrease silos and care and bring all the right people to the table. And so I think the thing that can be so devastating about dementia and the disease progression is the slowness of it, and how progressed the illness has to be if you're qualifying under a dementia diagnosis to be hospice eligible. How many years of struggle have that patient and family gone through. And so especially in this disease, we want to make sure that the second they're eligible, that we've had all of these conversations upstream, that we've done all of the seed planting and letting those seeds germinate around what exists under home hospice when that time comes, so that we can make sure that they're connected. Once someone is engaged in hospice, they are no longer eligible for the guide program. And that's the intention, providing this support upstream and connecting them to the incredibly robust services provided under hospice services. And so, but I'm excited to see how those conversations over time with patients and families will inform their readiness for hospice when that time comes. And, we're having hospice partners here who are meeting with patients who are not yet eligible. And so they're connecting them back with our guide program so that we can provide support until they do meet that criteria.
I guess I'll just go ahead and ask it to you this way. I love what you're doing. I love the innovation, the entrepreneurial spirit. It is kind of this wild, wild west. I've grown up in hospice. Most of our listeners are hospice. What do you see as the place for hospice in this future healthcare continuum where all these amazing innovations are being deployed? And maybe I'll put a little bit more kind of meat on the bone. Like I'm thinking of, Elizabeth Kubler-Ross and just what she was to this country, and, the catalyst that she was, the people dying in the acute care space, these dying patients that were like almost the untouchables on these wards. And out of that, Kubler-Ross and what she did, and then of course what was going on with Doc Cicely. I actually did know she was a social worker. Thank you. I forgot about that part of it. I knew she was a nurse and she had to become a physician. I forgot she was a social worker as well.
That's right.
But the confluence of all that, and then first off, hospices were kind of this all innovative, like bit palliative care, bit hospice, because there wasn't a defined benefit. But then 83, there becomes this defined benefit. I came in about 95, 70% or maybe 75% of hospices were nonprofit, 25% for-profit. Fast forward to present day. Now you got 75% for-profit, 25% nonprofit. You get a lot of skewing of what is hospice. And then yet you still have all these problems in the serious illness space. You've got the graying aging of America, the huge number of chronic diseases. So all that kind of sets the table for my question, Bree. I think you've got a unique perspective of what is the position and place for hospice in the future.
I think that's a great question. Like we're dreaming up the future that we want to build and that we will be the beneficiaries of at one point if we make these changes. So, I mean, I think from a patient and family perspective, all of the different silos that exist and the handoffs that exist are wildly disruptive for patients and families. Like you think about people who do really well under hospice care because it's comprehensive and they improve, and then you have to discharge them, right? There is a social justice component to that. And I would like to see, primary care continuing to get strengthened as the patient's medical home, but then have primary cares and hospices reach their arms to one another and create, this continuous team. And it would be wonderful if, interventions like ours could be deployed at the right times. And then, hospice services and palliative care services can be titrated up and down as needed. But the patients and families remain under a continuous care team. And so I think that's happening in some innovative ways, but, hospice is really moving upstream and finding ways to do that so we can better support these people. They're already going through so much in their changing bodies, and their, changing spirits as they approach end of life, that, to give them continuity and not have to know, oh, wait, I'm not on that anymore. This is my person to call. That's the future I want to see. So how do we build that?
That's a great question. I was sitting there kind of processing as you said that, if I found myself as a hospice CEO again, I would love to find a Bree in a holding group in my market service area, if you will. Yes, I would probably build a more palliative care provider model, so nurse practitioner centric. Find a great partner like you, stitch that together with my palliative care program, have incredible relationships with primary care as you described. I don't want to totally disrupt hospitals, but I would hope we would become the center of healthcare in the future and a little bit less acute as the center of that healthcare universe. Would you push back on that or maybe reframe that a little?
I wouldn't. And as we've been growing our work, my vision has always been for an army of very skilled social work practitioners, trained and ready to do this work. And so I would embed them. I guess that's the only change that I would make, is that we are moving towards trying to educate, building educational and training institutes so that on the nurse practitioner centric team that you're building, that we can have a social worker there. On the palliative care team that is taking risk, that we can have a social worker there doing this model, and the ACOs, that their members can access training to be able to deploy this type of model. So I would not push back on it. I think that's the goal, is to get this care to more people. However, we embed that.
You are such a bit of a unicorn. Where do you go? Where's the Bree factory? Where's the, where do you go find these amazing LCSW social workers that have your skill set? Like, have you found the perfect fishing pond? Like, is there a university in Colorado or some social work school somewhere that you found? I've always been an interesting student of like I grew up at KPMG, Pete Morwick, Arthur Anderson. In the early days would actually target a lot of Midwest colleges because of the ethic and ethos of people that were raised in that kind of culture. Then they had these like straight, like if you ever, Arthur Anderson was the guys with the white shirts and the dark ties, but they had an ethos they were looking for. There was a skill set and a common skill set that kind of came out of a lot of colleges like Notre Dame and colleges like that. And so, and it's interesting, when they lost their way, they were no longer able to go fish in that fishing pond of staff. Have you found something, because you have such a unique team that you've put together, or are you looking for those social work schools that are cranking out people with those skill sets?
That's a great question. And, as much as I'm a unicorn, the 3 social workers that I started this with were unicorns, and it was this very serendipitous, we all had different skills, and there's no way that I would be able to be here without what they brought to the table. So I think, they were unicorns in their own ways, and it really was together we were able to build this. There's no way I wouldn't have thrown my hands up and long ago if I didn't have all of us working towards this dream. But it is an issue. I mean, I think our team that we've built has had a lot of folks who have had palliative experience, and the schools are not training for this. They might do some serious illness theory, some education, but ours is a model, much like in the behavioral health fields. EMDR has a rigid protocol of how to, perform and to get trained in that, or emotionally focused couples therapy, or any of the various behavioral health models that are efficacious and needing advanced training. So I think that's what we're set out to do, is to be able to, we are recruiting a specific type of social worker, someone who is relentlessly trying to help people achieve informed consent, someone who is up for learning all of the medical components. But I think we have yet to see how we can create mass numbers of people who are well trained in this. And so maybe next year you and I can connect, and we'll see where we're at with that.
A good problem to be solved. Well, what final thoughts do you have, Bree?
Gosh, I'm just grateful to be in this space, and I'm grateful to all of the people who in their various disciplines, in their various venues, are working towards creating a better serious illness and end of life space. And so thank you to everyone who's just bringing their unique lens and whatever skills they have on the benefits of patients and families. And thank you to you.
Such a beautiful way for you to answer that question. I literally was having a flashback. And Katie, you don't stand there talking to Katie. You walk and you talk to Katie Lands. So I was walking and talking to Katie, and I said, "Hey, Katie, I'm thinking of a podcast, and I was going to call it a flight of substitution competitions. If you come to Asheville, we have all these amazing breweries, and they'll give you a flight of beers. It's like a sample of a bunch of," because I was trying to get my mind wrapped around all the different kind of flavors of innovations that are arising in the serious illness space. And she kind of spun around and looked at me, and she goes, "Why do you frame them as substitution competitions?" And it's a very businessy technical term. Clay Christensen has kind of coined the term. It's become very kind of almost in vogue to talk about, substitution competitions, disruptive innovations. And she goes, why do you look at them as competition? And it's more about collaboration. And like, you literally walked by and she's like, "You need to meet Bree." And that's literally how I met you. That was like the whole frame. You probably didn't even know that part.
I didn't.
And it's so cool to say it in that way, because if I was just like, "Well, I'm in this hospice and gosh, what you're doing is competitive to me." No, what you're doing is incredibly innovative and so complementary. Quite often we just rail against why did this physician just dump this referral and the family doesn't even know what they're expecting? And you've just been a beautiful innovation. So I could think about getting to know you, what you're doing, how Katie introduced us. It just encapsulates how my understanding is shifting. And I think that these incredible innovations in the serious illness space, we have so much collaborative opportunity. And I love your answer earlier. Right care, right place, right time is still more visionary of where we can go. And there's a good chance we could probably do that together. So just thank you for what you and your team are doing.
Absolutely. Absolutely. It's my honor. That's the truth.
Well, thanks to your team, Bree, and to our listeners, thanks to you. Make sure you subscribe to TCN Talks, pay it forward to friends, coworkers to make sure they get the benefit as well. And as we always do, we always like to close this show with a quote. And Bree picked this one and loved Dr. Atul Gawande. So this actually comes from his book, Being Mortal. And Bree picked this. A few conclusions become clear when we understand this, that our most cruel failure in how we treat the sick and the aged is the failure to recognize that they have priorities beyond merely being safe and living longer. That the chance to shape one's story is absolutely essential to sustaining meaning in life. That we have the opportunity to refashion our institutions, our culture, and our conversations in ways that transform the possibilities for the last chapters of everyone's lives. That is so well chosen, considering our conversation today, Bree. That was very visionary on your part. Thanks for listening to TCN Talks.